Dance program. So thank you again. But we hope, and we hope we will continue fastly tomorrow early in the morning, and maybe at the end of the session I will give information about our topics tomorrow. And now we move to session 5. And the session 5 related to standard laparoscopic application for kidney and upper urinary tract. And during the session, all participants will gain theoretical experience on basic laparoscopic skills and laparoscopic approach to kidney and upper urinary tract. And these lectures will be presented by valuable scientists, include the visual contents, and the participants will learn detailed anatomical landmarks related to surgical procedures of to project 3D models. And we will chair together Dr. Lada Eberlova from Czech Republic, and the first speaker is my dearest colleague Murat Bağcıoğlu from Kafkas University. He is an assistant professor in urology, and he was one of our residents when we were working together at Ankara Training and Research Hospital. And this is also a great pleasure to announce his speech today. He will talk on basic laparoscopic tools, technologic needs, and training box exercises for starters, for beginners to laparoscopic surgery.
First of all, I want to thank Dr. Huri and organizing committee to giving this chance of being a part of this well-designed training program, and also having the chance of working with medical students from other countries. And the work given to me by the organizing committee is introducing the basic laparoscopic tools, talking about technologic needs and training box exercises for starters to laparoscopic surgery. First of all, I want to explain why we are insist on laparoscopic surgery or minimally invasiveness, because over the past 25 years, the minimally invasive urology has become predominant, and an increasing number of studies compared to laparoscopic procedures with their open surgical counterparts. And the results showed us there is an equivalent efficiency and acceptable complication rates, as well as the laparoscopic procedures has some advantages like decreased postoperative pain, better cosmetic results, faster recovery, and a shorter hospital stay. The important trick to achieve success in laparoscopic surgery is to be very careful in patient selection. A detailed medical history focusing on prior surgeries, physical examination, detailing the location and extent of all abdominal scars are vital for patient evaluation. According to principle of primum non nocere, we have to know what we shouldn't do. So contraindications are, we have to know contraindications to avoid complications or life-threatening situations, and like uncorrectable coagulopathy, intestinal obstruction, significant abdominal wall infection, massive hemoperitoneum or hemoretroperitoneum, generalized peritonitis, and suspected malignant cysts. For both extraperitoneoscopy and retroperitoneoscopy, there is no need for bowel preparation and also for intraperitoneal laparoscopy. And blood trans, even there is a low chance of minor hemorrhage in laparoscopic nephrectomy and partial nephrectomy or nephroreterectomy. It's the lower rate, 3 to 12%, but it's advised to making a preparation for blood transfusion. And laparoscopic procedure can be performed in a chaos and under a chaotic mood because a lot of equipment, devices, tools over the table, stuff in everywhere, or before the procedure, you plan which device you will use and you will need which tool. And the positioning of equipment, surgeon, assistants, nurses, anesthesiologists, other support staff should be clearly defined and established for each laparoscopic case. So also a checklist should be made for before making a skin incision, and all the items should be checked, like irrigation aspiration unit is working, electrosurgical unit is working, carbon dioxide tank is full with extra carbon dioxide tank in the room, camera is white balanced, and light source is working, and also insufflation and varus needle is checked for flow. Our textbook, Campbell, advising to be ready for a conversion to open surgery for each laparoscopic case. So a separate tray with open laparotomy instruments must be ready for immediate use. The main topic for the laparoscopic surgery is to know anatomy very well and to have all the vision of operative field. Probably the most important tool for the laparoscopic surgery is the systems about the vision. It's possible to perform a procedure with a tower which includes camera control system and light source, insufflator, maybe a recording device. It can be complete with it. But if you have the chance of using an integrated operating system, like in the picture B, it could be more comfortable, of course. But it's up to economic capability of your hospital or your department. There are some systems called high definition, three-dimensional or 4K systems. They are all can be used for vision. Of course, every single corner of the operative field with high resolution makes the procedure pleased and comfortable. Light source is important, maybe more important for urologists than our colleagues from like gynecologists or general surgeons, because they usually work intraperitoneally and in short distance. But urologists work sometimes in deep pelvis and in retroperitoneal area. So it's advised to use at least 300 watts and preferably xenon light source to work. We usually use 0-degree lens system, but we are very familiar for 30-degree lens too, because of the other basic urologic procedures like cystoscopy and transrectal resection of prostate and bladder tumor. And also, varus needle is very, very important. The most important part of the laparoscopic surgery and the most important step, I think, because the most of the complications occur during this step, and access can be provided with Hasson, the open technique, but we should know the varus technique too. You can use disposable and reusable varus needle. Maybe it could be a trick to use the disposable one and the first and single use. It would be better because it's a very narrow needle and there's a spring system in it. And if a blood clot or a piece of tissue insert in it, then it mates the spring system. So if you don't have the pop and click mechanism, so you can't have the access, and maybe this can lead some bowel complications. There are a lot of kinds of trocars with advantages and disadvantages, reusable and disposable form. Reusable form are generally made of metal and they are heavy, and while during the procedure it fills your heart because of your movements, but the disposable trocars are generally made of plastic and they are lighter, and you feel more comfortable during your movements. But of course, it's all up to you. With experience, you will decide which one is suitable for you. But the most important thing for the trocars is about the tip of trocars. Because it's recommended to use the blunt tip, bladeless trocars to avoid organ injuries, intraperitoneal bleedings, or life-threatening complications of bowel complications, or major vessel injuries. And also there is a risk of incisional hernia on postoperative period. If you are working in retroperitoneal space, I mean, if your approach is retroperitoneally, then you will need a working space. So you have to create a working space, and you need this form. There are commercial available balloon dilatators or trocars with balloons. They are all suitable for this purpose. Hand-assisted laparoscopy is another type of minimal invasive surgery, especially in the beginning of learning curve. It's very useful and it's feel you in safe. With experience for better cosmetic results, then you can go level up and you can use single site or single port surgery. This type of minimal invasive surgeries are, you have to use their special trocars like this. Most of laparoscopic surgeons, this tool is more than irrigation and aspiration. Also, it's used for dissection of the tissues with the principle of traction, counter traction. So it's recommended for this apparatus the tip ovally shaped and blunt tip to avoid the complications. And sealing systems are another useful tools for laparoscopic surgery. And there are various tips in different trademarks like Ligasure, Covidien, Harmonic Scalpel. They are all have the same principle. There is a recovery time, and during this time, the machine fulgurates, coagulates, and cut the tissue. So they require less blood loss and less tissue damage. It's again, it's up to economic capacity of your hospital or your department, and there are lots of paper that compare these systems, and the results showed they are all in same efficiency and in safety. For laparoscopic instruments, we can say you can find every single instrument which you use in open surgery in laparoscopic type. Scissors, graspers, dissectors, dolphin type, duckbill type, right angles, needle holders. They are all in reusable and disposable types. And of course, with experience, the surgeons make a list of the devices, instruments which he or she will use, or a box he prepare it. Stirring and knot tying are the most difficult tasks in laparoscopic surgery. A significant amount of practice is needed to achieve sufficient level of proficiency. In addition to start rigid needle drivers, some companies have recently developed articulating needle holders that aid in obtaining more optimal stirring angles with the needle. There are various types of clips like titanium, polytetraethyl as called Hem-o-lok clips. Both has advantages and disadvantages, but the Hem-o-lok clips are known the safest clips. They are in non-absorbable form, or you can use a surgical type of surgical stapler, endogia. So its working principle is stippling in two sides of tissue and then automatically cut the middle. The safety of the product has proven before, but we must be very careful to using with endogia before. We shouldn't any titanium or Hem-o-lok clip in the stirring area. So we will have some trouble with opening it. Simulation has become an integral part of surgical training, and you will see this in this training program. Because the simulation programs with training box exercises are safe mode of developing surgical skills, hands-eye coordination, triangulation, and depth perception. And commercial laparoscopic trainers are usually expensive, and it makes it inaccessible for trainers. Instead of them, inexpensive and homemade laparoscopic training box can be done. And also, it's possible to achieve it or make it with a webcam or a light. Even you can make it available with an application which allows a smartphone camera to a remote control. And with smartphones or iPods and boxes, it can be done. And there are a lot of training box exercises in the net, in YouTube, all of them about the practicing skills as orientation in the laparoscopic environment, training of eye-hand coordination, depth perception in two-dimensional picture, and bimanual handling, manipulation of laparoscopic instruments, and correct application of clip applier and atraumatic grasping. All the box basic exercises generally about object transfer, tissue dissection, working with scissors, and knots tying, and endoscoping string on models. At the end, there are some videos of laparoscopic exercises. Thank you for your attention.
Murat, thank you for this nice and basic presentation. Especially, it is very helpful for us to show the important tips and tricks on to using some laparoscopic instruments during the surgery. And we already prepared all tools, laparoscopic tools for the nephrectomy models, but just to feel the how trainee should learn the nephrectomy technique or to dissection and some suturing. I would like to ask to you a question about the training. What is your objective opinion on the training for laparoscopic surgery?
It's
in your own career.
I can't say it's useful. I can say it's a must for laparoscopic surgery. And in our clinic, we have two laparoscopic box, and our residents and my colleagues are still working on it.
Any questions and comments? Yes, Ayşe.
Thank you, sir, for your great presentation. Since there are medical students among the audience, I want to ask something, especially for them. In fact, the mentoring is very useful in urologic surgery because if you are studying with a mentor at the beginning of your new surgical career, you feel more confidence and etc. According to you, how many cases should be performed in front of a mentor before you start your real alone surgery?
In fact, it changes for the procedure. If you plan to make a radical prostatectomy, I think you need at least 30 or 40 cases with the mentor. But if you plan making a procedure, the kidney cyst decortication, maybe 10 cases are enough.
Okay. Thank you, Murat. The next talk will be presented by Dr. Berat Cem Özgür. The topic is step-by-step anatomic laparoscopic nephrectomy. He is associate professor at Ankara Training and Research Hospital.
Bağlamak lazımdır abi. Açacağız mı? Açacağız. Okay, thank you very much. In this section, I will try to summarize you the basic steps of a well-known surgery in urology. That's laparoscopic nephrectomy. Sometimes I will mention it as laparoscopic nephrectomy and sometimes simple or radical nephrectomy. The main difference is, as you know, most of you probably know, opening the Gerotas fascia, the fascia that surrounds the kidney, or not. If you open the Gerotas fascia here, that's name is simple nephrectomy for benign lesions mostly. But if you don't open the Gerotas fascia and remove the specimen wholly, then its name is laparoscopic radical nephrectomy. As you know, laparoscopic nephrectomy takes place for more than 40 years in many urologic clinics, and our clinic also performed this surgery for a few years. There are two ways to approach to kidney via laparoscopy. One is transperitoneal way, the other is retroperitoneal way. In some sources, you can see transperitoneal way as intraperitoneal way. In some articles, books, it can be named as intraperitoneal way. Both ways have some advantages and disadvantages. In transperitoneal way, you have identifiable anatomic landmarks. You have enough place to work on, but you open the peritoneal cavity. But in the retroperitoneal way, the urologists are familiar to this way. It mimics traditional open surgery. But it has difficulty with orientation, visualization, thoracic spacing, and organ entrapment. We mostly perform transperitoneal surgery in our clinic. That's the patient positioning. 35 degrees modified flank positioning is the best position to us. The upper leg is extended, as you see here, and the lower leg is flexed. Where is the place of the first surgeon, assistant, and the nurse? If you will perform a transperitoneal surgery, the first surgeon and the assistant will be just in front of the patient. But if you will perform a retroperitoneal surgery, you will just behind the patient. And this is the place of the nurses. That's another view. The level of the monitor will just be at the level of the eye of the first surgeon. There are some basic steps of this surgery, as all surgeries have. Placing the ports, mobilizing the colon, if you are performing, and most clinics I know perform the transperitoneal surgery, mobilizing the liver and the upper pole, coherizing the duodenum, freeing the lower pole, dissecting the hilum, and dividing the ureter. In three-port technique, and most of urologists use this technique, you need only 3 small incisions, less than ½ inch. Sometimes, if you are not able to remove the specimen, you can give another incision, like a Gibson incision. It's nearly 2 inches long. That's the traditional places of the ports. That's the camera port placement just on the umbilicus. That's the 5 mm left-hand working port place. And that's the 10 mm right-hand working place. But in our clinic, we usually place the ports 1 or 2 centimeters above or lateral to these dots. You will make a triangle to work on. Before the thoracars are placed, the abdomen is insufflated using a Veres needle, as Murat Bağcıoğlu excellently experienced. And that's another view where just the ports are. As a summary, 10 mm umbilical camera port for the 0 degrees telescope. Sometimes you can work with 30 degrees telescope. 10 mm right-hand working port. 5 mm left-hand working port. 1 or 2 5 mm ports can be placed for bowel or liver retraction. Here you can see the 4th port is placed for liver retraction. Of course, when you are working, when you will perform a retroperitoneal surgery, you have to be on retroperitoneum. The AB line denotes the paraspinous muscles. The X denotes the camera port. The others are left and right hand working ports. That's the 11th and that's the 12th rib. And you have to create a space by your finger or by a balloon dilatator. As I mentioned, this is a very limited space, and you have to create this space by your finger or a balloon. The reflecting of the colon is the first and important step of this surgery. You know the line of Tolt. It's an avascular line, just lateral the ascending and descending colon. You have to incise it at least 5 or 10 centimeters long to get such a vision. When reflecting these intestinal segments, some intestinal complications may occur. In order to avoid these, energy sources must be used in attention. Of course, some ways exist in order to control these complications, but in order to decrease the morbidity, you have to be very careful. Mobilizing the spleen, upper pole, or liver is another important part of this surgery. You have to release these attachments, the upper pole attachments. You don't have to remove adrenal gland in both radical or simple nephrectomy. Here the Gerotas fascia is not opened and the attachments are releasing. The most important part of this surgery is identification the renal hilum. Some anatomical features must be known. On the right side, we have a short renal vein. On the left side, we have a short renal artery. Also, the right gonadal vein drains directly to vena cava inferior, and the left gonadal vein brings us to kidney. You have to be very calm and careful when dissecting the hilum. Here the metal clips are used, but we usually clip the main arteries with hemlock clips. From top to bottom, on the top, the renal vein stays. Then you can see the renal artery, and on the bottom you can see the renal pelvis. At least 2 clips must be clipped on the medial side of the renal artery and vein. Here also the metal clips are used, but hemlock clips are safer. Last, ureteral dissection takes place, but some surgeons, as I will show you a short video clip, make this dissection first. It can be a choice from surgeon to surgeon. While dividing the ureter, the gonadal vessels must be taken in consideration, and here you can see releasing the posterior and anterior attachments. Then you can see such a vision after taking the specimen out. You can use endobags that can be available on the market to remove the specimen. And I'll show you a short video clip. Here the procedure starts. The thoracar positioning. 3 thoracars are inserted.
Perform a transperineal refractomy and start deflecting the colon.
The first step is deflecting the colon, as I mentioned.
The psoas muscle is exposed.
You will see the muscle of psoas. Then you are sure that you deflect the colon to avoid of intestinal complications. You have to medialize the colon. Here, the surgeon starts with lifting the ureter.
The ureter is dissected and can be
It's
lifted
not my own
centrally
video.
by the trim skin to avoid unnecessary extra trocar ports.
Here he lifts the ureter up by his own technique. We usually start with releasing the upper part of the kidney. But it's a trick of him. He lifts the ureter up and goes to upper pole and renal hilum. The intra-abdominal pressure is 15 millimeters mercury now. The best pressure is that.
After dissection of the upper part of the kidney, the renal pedicle can be dissected. First, the renal vein is visualized and behind it the artery is found. Using stem dissection, we individualize the different vessels and create enough space to use hemlock clips to secure both the artery and the vein.
Now the clipping vascular pedicle. At least 2 clips on the medial side, as I mentioned here. But he clipped the third to feel confident. This is the renal vein. We have to first clip the renal artery as a surgical rule.
Scissors are used for careful cross-section of the vessels. Note that different vascular anatomic variations exist. Before performing laparoscopic nephrectomy, the surgeon has to ensure his knowledge of the anatomy of the renal veins and arteries in every case. Pre-operative.
Okay. Thank you very much.
Thank you, Cem. Any question? Yes, Özer.
Thank for your presentation, sir. I want to ask some questions on Hill's dissection. I made my residency in a center that the using Hem-o-lok clips for hilum dissection was standard, and during my residency period I never seen any nephrectomy using staplers in the hilum. But anyway, using Hem-o-lok clips, even the original ones, are contraindicated in donor nephrectomy by FDA. Any patient loss because of hilum bleeding can be a matter of prosecution. So after I graduated and I started my own practice, I started using staplers because of my inability, because most of the times I was bleeding in hilum, and then I chose a shorter way and I placed the stapler at the hilum, and after then I saw that it is easier and it works, and also from a medical legal side it's safer. I want to ask your own experience on using Hem-o-lok clips versus staplers, and also I want to thank you very much on the presentation of using Kate needle to elevate the ureter in your video. The technique was described very detailed in the first edition of Essential Urologic Laparoscopy, which was edited by Stefan Nekada. But after growing experience on laparoscopy, most of the surgeons left the elevation with Kate needle, and some people see that maneuver is part of starters. But I think it's a very tricky maneuver, and it always gives you more time and better view. I thank you for the presentation of the using Kate needle. Thank you.
Thank you. The FDA did not improve the usage of Hem-o-lok clips because of some complications in the literature. But I don't have an experience using the energy sources while clipping. We in our clinic perform this surgery by Hem-o-lok clips, but metal clips can be also used. No, we don't have an experience on endogia, but I know that some clinics use this technique, but I don't have enough experience on this subject.
Any comment, Nada? Okay. Thank you, Cem.
Okay, thank you.
Our last talk about the tips and tricks for laparoscopic suturing and renal applications. Dr. Özer Ural Çakıcı. This is our last
Thank you, and hello again.
talk. Yes.
I'm sorry, bro. May someone help me? Okay, okay. Hello again. This time I am gonna be in here and I will talk about practical skills in laparoscopic suturing. As my colleague Dr. Bashoğlu said, that suturing is the most tricky part of laparoscopic reconstruction surgery. I wish I could say that I'm a master of this thing, but unfortunately I cannot say. Also, I think the partial nephrectomy and pyeloplasty should be undertaken with robotic assisted surgery, which is easier, feasible, and it's available in our country. Therefore, after I came back to central hospitals, I left performing partial nephrectomy and pyeloplasty. But my experience is based on mostly a rural practice, which I was living in behind this door in a small house, and this was my street fund friend Vitamin, and this was not my hospital. My hospital stays at here, is in front of my hospital. I had no blood banking, no ICU, 2 hours distant from a third step center. Now, first, we will start with partial nephrectomy. Partial nephrectomy has a well-described open technique which is feasible in every practice. Now, what are we doing in partial nephrectomy? We are resecting a circular mass from an ovaloid organ and then suturing the organ in a respectively linear fashion. To understand this, I want to take you inside the world of dimensions. I'm sorry, I can't stay here. Also, these illustrations, thank you very much. These illustrations by my wife and completely original for this talk. So I want to take you into the world of dimensions. In the world we live, we have mainly 3 dimensions: the x-axis, the y-axis, and z-axis. So while we are performing a resection, we are making a circumferential dissection to take out the mass from the kidney. And then we are returning to 2-dimension system for suturing. Now, my trick that I found while performing this surgery in rural hospitals was based on the dimensions. Now, I start in this point to my suture with my needle holder at this point. Now, if I take the y-axis along the line of suture, this is my choice, the y on the line of the suture, my needle stays on the z-axis and my needle holder comes from the x-axis. Then my point aim is getting my needle a forward point in the x-axis and in the another point in the y-axis. Therefore, never make your needle holder moving in both dimensions. Okay, put your needle in here. So what is suturing from your point of view? Suturing is needling. So where is your needle? There is your suture. If you insert your needle at here, say 0x, 0e, and if you take your suture at say 2x, 0e, then you will return to another point, say 2y and 0x. And this thing every time reverberates itself. then you will never lose your point at three-dimensional world. So laparoscopy is a master-slave system. You see you are the master, you see your movement in 2 dimensions, but your movement has a reflection in 3-dimensional world. And we have another technique which comprises pre-positioning the needles under the mass, and during resection, forwarding the sutures and making at the same time a resection. I think this is very feasible, very beautiful, but I did not perform this technique. Now, if we take the total movement, which improved my suturing in laparoscopy. Now, this is my hand. This is my needle holding position, as you see from here. I am holding the needle, and this is the mass. I am getting into the mass. So my net movement has 2 dimensions. If you make this movement in 3 dimensions, for example, if you are not making your movement like this, it can be, but this is problematic. Probably you will miss a hemostatic point of the vessels. But if you are making your movement as this in 2 dimensions, then you will get what you see on the screen. You see my net movement. If we take a look at the axis at here, there is a movement in X and Y dimensions. And my second movement, you see the needle and you see my net movement, has 1 dimension only. I will end with a mirror image of entrance of needle, and then my favorite part, I am returning to my starting point in the 3-dimension world. This will save your time. This will not let you to fall in an unknown place, and this will aid your hemostasis. And you see my net movement is absolutely 0. After finishing my 1 suture with the 0 movement, I will make a movement with my needle holder in Z-axis. Then I will forward this Z-axis movement will forward my suture on the linear suture line. If we take a look at the pyeloplasty, which is a circular incision which is closed in circular fashion, and that's I always fail. I could never make a complete circular suture with pure laparoscopy, but my mentors, who are very experienced in robotic system, are making these sutures very well. That's why I refer my patients to them. But if you place 2 stay sutures at 6 o'clock and 12 o'clock, then you will have a 2 linear suture lines on both sides of the stay sutures, and you can manage your sutures with my 2-dimension technique with 0 net movement. The 0 movement will give you more time and will make your operation better. Thank you.
Thank you. Is there any question or any comment? I think your presentation and your viewpoint on the suturing is completely related to our project. Why? Because I know that you completed your residency in a clinic. It has a robotic section, and this 3-dimensional experience or the presentation of the suturing, I believe that should be worked more and more. I'd like to ask to you how we can improve the suturing technique. Although you you are doing some two-dimensional laparoscopic suturing, because on Saturday we have a training box, we have a kidney tumor plus, and as Jem mentioned about that, the simple and the radical type of the nephrectomy and the partial. But of course, we have a limited models. We should secure and not harvest the models anyway. But the technique, what is your plan to train our residents and the students with the laparoscopic surgery based on the suturing?
I thank you, sir, for your question. First, I want to make a small review of my history, my own story on laparoscopy. I started my residency in Atatürk Training and Research Hospital, which is a third step center for oncological surgery. And now the team has more than 2,000 cases in robotic prostatectomy, which is a very good number in my opinion. And they are a very experienced team. And then I was an observer in Germany under the supervision of Professor Rasweiler in Heilbronn, and then I could improve my laparoscopic skills in their laboratory in training boxes and animal models, non-living animal models, I'm sorry. And therefore, I found that the suturing requires real ability, which you need to work every time, and I saw that Professor Rasweiler still working on his suturing abilities, which was very inspiring for me. But on the other hand, we have a technology, robotic technology. Therefore, I think the question is whether we need to perform the elective cases with pure laparoscopy or not. From my point of view, we should not. And then I left performing. But to improve our laparoscopy, and my advice to my friends, resident colleagues, are first working on training box. Second, thinking about what are you doing. And making and training every time, every second, because I saw that even the leaders of the laparoscopy are training on their boxes still after maybe 20 years of practice and after 100 cases. And so first understanding what are we doing. This is very important. We are performing a 3-dimension movement with 2-dimension view. So we have to understand that, and the hand ability is important. It becomes better with training box exercises. And then my best advice is, after starting your practice, leave elective cases to robotics. This is my point of view.
Okay, thank you, Özer. Any questions, comments? Okay, thank you. And now we reached the final of the day. We finished the day. There's a first learning, training, teaching activity, and tomorrow we will talk more technical issues related to 3D modeling, how we are performing the 3D modeling, of course, based on more functional anatomy and the functional surgical procedures. And of course, it will be completely related to our models that we will start to use on Saturday. And we are talking about these lectures for why. First of all, you will gain, maybe, of course, we believe that you will not get 100% presented in your mind, but you will get a little bit, should be the familiar, what you will do on Saturday, although you are surgeon or not. But according to the literature, it's completely reported that you can be the student, you can be a resident, you can be the urology. Although in robotic surgical section, and the papers reported that some students did better job than more experienced robotic surgeon during the during the hands-on training session. So we will leave that within this group. There will be many expertise on endoscopic surgery, surgical skills for the future. And such a kind meetings will also explore yourself. You are keen to do the surgery, you are keen to use the endoscopic technique, and you are keen to understand some 3D modeling. So this is important for us to increase the awareness, mindfulness, maybe it will be better terminology, the mindfulness of yourself and your skills to when you to do your career for the future plan, to select the surgery or not, or if you are an engineer and you can start to work with the medicine section, and especially Professor Moon probably will say something about tomorrow, because also we will have the global section meeting tomorrow, IEEE 3D-based medical application working group meeting here. So this is very important for us because we are talking about the standards, standardization on visualization, 3D modeling, 3D printing, and simulation. So it is important, very important, your suggestion for us, because these standards will be the global standards. The global standards will be from our meeting. So Professor Moon, can you say something about the, I believe that we have an IEEE group, our university group, Hacettepe University, they will so keen to give some their experience or their suggestion on that. Professor Moon, can you say some words on maybe tomorrow, because you know the advertisement is important. You know that we have some advertisement for to start. We will start at 9 tomorrow with the talk with the Professor Yang Lee Moon.
Just before talking about me, I was just enjoying with my virtual reality things.
It works?
It works, yes.
It's great.
I just download the center computer. Okay. Yes, our standard is very useful for our medical future. It means if we produce virtual reality and 3D printing standard, then it is not only for medical the practitioner, but also for medical trainee, students, and medical industry will developing together. So we can provide such a basement from the European and the United States, North American standard will be support this basement together. So I'm so proud of working together with Dr. Emnuri and the Professor Alberto Paolozzi from Europe and the Pilsen and the Greece. So we can provide, we can promote our working. Then our working the group will be very. The primary effort will provide, yes, most important the point of the not only for medical but also for industrial part. Yes, that's my issue.
Thank you, Dr. Moon. Actually, I have a really important memory with Professor Moon. We started to work maybe for 2 years with one of the meeting at Hacettepe University. I was also the general director of the training center. So I was very excited to make this 3D planning, but I suggested to Professor Moon, we should do more complex cases, more complex surgery. But he said that it's really, I think I suggest you to also, this is my first class, as you remember, the basic training. We should think basic. And if we do innovation, if we want to do innovation, if we want to do some new and novelty, we have to reach the basic knowledge, and we have to think basic. So that's the reason for we decided to make the VR cystoscopy model. Probably everybody can say cystoscopy, oh yes, it's very easy, just take it in and out. So, but when you look at the VR cystoscopy on Saturday, you can see some tips and tricks on doing the cystoscopic model. And also the other models we were together just came from the very basic thoughts. And today, in my opinion, all speakers talked really basic and the common issues in urology and the surgical basis. And I hope tomorrow we'll have a really enthusiasm for each participant. I would like to thank to you for the first day, for the participation. And now we are closing the session. Thank you.
Thank you.
At 9 o'clock, we will start with Professor Moon.